morning, everyone. Thanks, Anjali, and the HIV-NAT team for the invitation to speak. It's always good to be here and meet up with old friends. I was very much looking forward to seeing Tui this morning in person. Very sad that we're separated by a wall in a hotel room, but get well soon, Tui. Let me see if I can just adjust this. There we go. So here are my disclosures. And this is what I'm going to talk about. I'm going to focus on drug-susceptible TB treatment regimens and the advances there. I'm not going to talk about ART because Anjali covered that brilliantly yesterday. And I'm not going to talk about MDR-TB. Of course, there's been major advances in treatment shortening in MDR-TB because Vidya gave a very nice talk on that yesterday. So I'm going to talk about briefly the current standard TB treatment for drug-susceptible disease and what's wrong with it. And then how can we make it better? And I'll cover three areas: new and repurposed antibacterial drugs, immune-based therapies, and then new strategies. So first of all, current standard treatment for drug-susceptible disease. You all know 6 months of treatment, 4 drugs, rifampicin, isoniazid, pyrazimide, ethambutol for 2 months, then a continuation phase of rifampicin, isoniazid for 4 months. And this was first established in the 1980s. Has a high efficacy in clinical trials. Actually, it's fantastic in clinical trials, 95% cure rate, very hard to beat. But in program settings, that efficacy drops off to 80, 85%, or sometimes less because of difficulties of adherence and delivery. Not forgetting the other aspects of any treatment, so safety. Actually, the standard treatment is not bad in terms of safety. In clinical trials, which is really the only place we count these things, about 20% of people develop grade 3 or grade 4 adverse events. Tolerability is really good. In trials, less than 2% discontinue due to adverse events. The resistance risk in trials is very low, but as with the efficacy, that drops off or increases in terms of resistance in treatment programs, again driven by non-adherence, interruptions, problems with delivery. The pill burden is relatively modest, 2 to 4 pills a day for most people in a body weight range, and then drug interactions, obviously a problem with particularly rifampicin. The vision for the last 15, 20 years really has been to shorten treatment, and this is an old slide from the TB Alliance when they first started 20 years ago about their vision, which was to get to a 2-month regimen, and then a bit more fanciful in the future to get that down to 10 days. They pretty soon changed their mind about the 10 days, but actually they're coming back to that now because of the successes that I'm going to talk about. But most people in the field are thinking 2 months is about the right target, an optimistic target for where we're going with treatment in the foreseeable future. Why do we give more than 2 months? Why do we need to give long courses of therapy? Well, because the TB bacilli, when exposed to antibiotics, like many other bacterial infections, go into a dormant state when they're phenotypically resistant to antibiotics, and you need to treat for a long time to make sure you eradicate the very last bacillus, because if you don't and you stop treatment, in many cases that will set off a new chain of infection. So I mentioned 3 potential approaches to shortening treatment. Everybody thinks about the first one, which is, oh, well, let's make better drugs, antibacterial drugs, and regimens that are better at sterilizing, killing off these last dormant bacilli. And I'm going to cover this one first of all because this is where most of the activity is. So the main challenge for developing TB drugs, is no surprise, has been the resources devoted to the task. And if this is HIV drug development in the fast lane for 30 years or so, very well-resourced, this has been TB drug development, under-resourced and moving at a very slow pace. And resourceful investigators with not too many research funds around and not too many drugs to try have looked at repurposing or optimizing existing antibacterials, and that's met with some success. So the quinolones was the initial example. I'm sure you're all very familiar with that. So repurposing quinolones for treatment in TB, they work, at least in lengthy regimens. Linezolid was another big success. It's gone down the MDR-TB pathway, but linezolid at lower doses or possibly alternative drugs in the oxazolidinone class may have a role to play in drug-susceptible TB regimens. I'm conscious I've got no clock here. So I'm just going to talk, and Don, if you don't mind, just sort of waving at me when it's sort of 10 minutes before or something. Thanks. Sorry? Okay, thanks. So there has been one big success in drug-susceptible treatment regimen shortening. It says successes. That's maybe a bit optimistic, but and that's the rifapentin moxifloxacin regimen. So study 31, ACTG 5349 trial, compared standard of care 6-month regimen against 2 4-month regimens substituting rifapentin for rifampicin. In one of them, they also substituted moxifloxacin for ethambutol. The top panel here shows the non-inferiority in the study populations, the selected populations for analysis within the red box. Is the pointer working? Yes, good. So here's your non-inferiority margin. You can see that with the rifapentin moxifloxacin regimen, it met the non-inferiority criteria. With the rifapentin alone regimen, you can see those confidence intervals are outside of the non-inferiority margin, so that did not meet non-inferiority criteria. And safety-wise, basically similar to standard of care, no excess of severe adverse events. So this has made it to the WHO treatment guidelines, rapid passage through, but there are implementation challenges. Firstly, you need to do susceptibility testing, effectively introduce universal DST. We've got rifampicin with the gene expert, that's already available, that's easy. But you also need to test for isoniazid, in areas with high fluoroquinolone resistance, you'd need to introduce fluoroquinolone susceptibility testing too. You need directly observed therapy. In the trial, they did very fastidious directly observed therapy, 5 days a week. That's quite hard to replicate in program settings. The pill burden is high. Oh, the clock's back on, great. The pill burden is high because the rifapentin comes in small pills. That's potentially surmountable, but at the moment it's a high pill burden, and there's no fixed dose combination. Again, these may change over time. The cost is higher than the standard of care. Pretty much anything is going to be higher than the standard of care because it's been around so long, it's generic and so on and so on. You need to give it with food. And then you need to really change your programs. You know, you've got programs that have been used 30 years doing exactly the same thing, huge industry procurements around that. You'd have to change the entire program to change the regimen. And that's no trivial undertaking. We know it's done in HIV, but it's a major change. And so essentially the uptake of this 4-month regimen has been somewhat disappointing. It may change over time, but I think people are also holding out for something, if you're going to make these degree of changes, something that's going to have a bigger impact on treatment duration. It's clearly coming, and I think the rifapentin moxi regimen is moving into practice in some places, but I think people are looking forward to further developments. In parallel with the rifapentin development, there's been a lot of activity in trying to optimize the dose of rifamycin. We've traditionally dosed rifamycin right at the bottom of the dose response curve, and people have been looking at pushing up the dose of rifampicin to 35 milligrams per kilogram, sometimes even 40 milligrams per kilogram. This is a typical culture conversion 2B trial. You're looking at the rate of culture clearance, and you can see when you push up the dose of rifampicin to 35 milligrams per kilogram with the other standard TB drugs, you get faster culture conversion. And that's now been tested in a randomized controlled trial that's just come out at the end of last year called the RifaShort trial, which compared a 6-month standard of care regimen versus 2 4-month regimens, one with 1,200 milligrams of rifampicin, so essentially double the normal dose, and an arm with 1,800 milligrams of rifampicin. They had unfavorable outcome, essentially relapses, that's standard for these trials, a non-inferiority margin of 8%. And they had the smart idea, which I'm sure they now regret, to keep the sample size down. They proposed a hierarchical testing approach. So first of all, they test the 1,800 milligram dose, the highest dose for non-inferiority, and then only if that shows non-inferiority, then they look to see, well, can we still achieve that with 1,200 milligrams? So these are the results. Non-inferiority margin 8% here. You can see the SR2, the 1,800 milligram dose of rifampicin, did not meet the non-inferiority criteria, and because that was their pre-specified initial hierarchical test, officially they could not go on to test for non-inferiority the SR2, the 1,200 milligram regimen, and that just about made it within the non-inferiority criteria. So it's difficult to know what to conclude from this trial, other than there may be something in rifampicin at some higher dose. We're probably close with it. What might have explained that somewhat paradoxical finding of higher doses of rifampicin having worse efficacy? It's our old friend, probably safety, although the adverse event, severe adverse event rate reporting was quite low in the trial. This is some data we showed at the Union conference a couple of months ago in Paris, where we've looked at PK exposure levels with high doses of rifampicin and GI intolerance. And you can see there's a clear association between high levels of rifampicin. It's very variable in individual patients, but this was looking at doses of 20, 35 milligrams per kilogram. You get a clear association, though, with higher levels of rifampicin, higher exposure of rifampicin, you're getting more GI toxicity. That's often not picked up in trials, but in real-world settings, that's what's causing people to miss doses and potentially can take the edge off your efficacy. So the answer is that probably the higher you go with rifampicin, more efficacy you're going to get, but there's probably a sweet spot which may differ according to many factors, including race, because of metabolic factors that could really set the sweet spot, something a bit below 35 milligrams per kilogram. So that's repurposed drugs. What about new drugs? This is the TB drug pipeline, the newest one, updated in, that's 1st of November, it's the American way round, just fresh off the press. And if you look at phase 2 here, that's a very full pipeline. Oncologists would laugh at this, but for most bacterial infections, that's really quite impressive to have so many new drugs in phase 2 trials. And the asterisks denote drugs with from new chemical classes. So you can see there's lots of new drugs from new classes, and that's great news for being able to potentially find a new non-overlapping regimen with different mechanisms of action that could be a new standard of care. So very exciting activity with that. And the other thing that's really important is a whole bunch of new funding coming into TB drug development. So in addition to the usual suspects for many years, the TBTC, the CDC in the US, NIH through the ACTG, the EU through EDCTP, UK is a big funder through MRC and Wellcome Trust. In addition to these, there are two big pots of funding, two big commitments here. One from the EU, 100 million euros to a consortium Unite for TB plus matching industry funding, and then the equally deep-pocketed Gates MRI that's put money into another project to bring these regimens, these phase 2 drugs into clinical trials and rapid development. So really, in the last 5 years or so, TB's moved into the fast lane. Lots of new drugs, lots of new funding. And the other thing that's come with that is new ideas for trials. So the old ways of doing TB trials, you start off with a phase 2 culture conversion trial, similar to the ones I've just showed you, to identify your single regimen versus the standard of care. Then you'd move into a 4-month phase 3, probably take you 5-7 years, and then if it works at 4 months, you go to 3 months to see if that works right. Then you go to 2 months, and 30 years later or thereabouts, you'd have a new 2-month regimen. The new model is that you put a lot more activity in at the phase 2B stage, so test multiple regimens, And then you use a duration randomization trial design. So once you've picked your promising regimens, you put them into a randomized controlled trial that looks at 2 months, 3 months, 4 months within the same trial, and potentially that could give us answers much more rapidly on which regimens can move forward and what would be the potential for dose reduction. And here's the Unite for TB flagship trial. It's called Paradigm for TB. The Gates-funded pan-TB trial is a similar kind of approach. So actually there's something like 11 different arms in the phase 2b, all based around 2 new drugs, a GSK drug now called ganfeberol and a drug from LMU in Germany called BTZ-043, and different combinations of regimens. The best ones will then progress to what we call a 2C trial, which is this duration randomization design. So this is now just about to recruit the first patient and just opened 2 sites. And the Gates similar approach is also moving forward and is actively in recruitment. So that's conventional antibacterial drugs, new drug regimens, very exciting time. Neglected in TB, and really it's a shame because it's kind of obvious. If you're having difficulty eradicating dormant organisms with antibacterials because they're phenotypically resistant, we know the immune response works pretty well against TB, otherwise everybody with latent TB would be reactivating and so on. So why not try and improve the immune response to help clear away some of these bacteria? And this is really rudimentary. It's really in the stage of 2B trials, so culture conversion trials. I'm going to show a few examples. One is run out of Singapore, and Gail Cross, who was with us at the time, now moved back to Australia, was leading this, in which we compared standard treatment plus adjunctive rosuvastatin 10 milligrams a day for the first 8 weeks of treatment. Reasonably sizable trial, 137 randomized. And you can see, so the rosuvastatin arm is in red. There's a suggestion that maybe it's doing a little bit better. The hazard ratio for culture conversion was a bit higher with the rosuvastatin, but it wasn't statistically significant. It looked to be a bit better in Asians, actually. We did the trial in collaboration with the Philippines and Vietnam, and as well as sites in Africa. Seemed to be okay. That interesting, but nothing compelling at this stage. Needs some further investigation. And then Padma from Chennai and colleagues in India, similar kind of approach, standard of care versus standard of care plus metformin. Metformin has anti-autophagy effects. The graph is flipped, so this is culture sterilization, so faster, or higher is faster, which is better, and you can see there's a suggestion that the control arm is doing better here. Didn't quite reach statistical significance, but nothing really encouraging there, although there was a suggestion of faster cavity closure and some immune inflammatory benefits. And then there was a NIH-funded trial done out of the Aurum Institute in South Africa looking at a bunch of immunomodulatory drugs. Again, no effect on culture conversion, but in this one, they found some signal on spirometry improvement in one of the arms. The problem with this field of the immune-based therapies is we don't really know what is the right endpoint. So we're using culture conversion, that being the thing that we understand, but actually there may be benefits if you're looking at effects on lung, fibrosis and so on. You probably need different endpoints, and the field is a sort of stage of finding its feet to work out how to move that forward. Now, lastly, innovative treatment strategies, taking what we've got and trying to find better ways of using this in programs or in individual patients. And I'm going to spend most of the rest of the talk talking about the Truncate TB trial. The rationale for the trial is that if you look back at the old literature, before we ended up with a 6-month short course regimen, there were some trials of 2 to 3 months of standard drugs, very small, interestingly done in Hong Kong, showing that relapse rates with 2 to 3 months of treatment were higher. That's why it wasn't adopted, that's why you went for 6 months, but not catastrophically high. It was 10 to 15% relapse, the highest one was 18% relapse. If you turn that around, that's telling us you can cure 85% of people with 2 to 3 months of treatment. right? So what that means, if you translate that into English, is with 6 months of treatment, we're over-treating the majority of people, 85%, to prevent relapse in a minority. Sounds a bit of a strange way of thinking about things. And so the idea behind truncated TB is, well, maybe we can flip that and maybe get better outcomes, particularly in a program setting. If you treat everyone with a shorter duration that's needed for the majority, and then shift those resources to ensure early detection and retreatment of those relapses that will occur in the minority. And this might have benefits to programs, and also might be quite appealing to people who need to be on treatment for TB. So to test this, we defined a strategy, which is 8 weeks of treatment, some wriggle room to extend that a little bit. If people were still symptomatic or smear positive, they could add on another 2 weeks to 10 weeks, assess again if still symptomatic, smear positive, go to 12 weeks, but then stop. And then they're monitored. And we used symptom checklist once a month, mostly by telephone, a smear once every 1 to 3 months, initially more intensively, then spaced out. Some people would relapse, we know that, and those people were picked up and retreated with standard 6 months of treatment. In a trial, we need to compare that with standard of care. The trouble is with a normal trial design which counts relapses, we know that the strategy arm would do worse. We know there will be more relapses, so there's just no point in using that as an endpoint. You need a meaningful medium to long-term endpoint. So we define one at 2 years, 96 weeks, so-called unsatisfactory outcome. How many people have died, still got active TB after 2 years, or still on TB treatment at 2 years? If the strategy is non-inferior on that medium-term outcome, you still got well people alive doing perfectly fine, then you can look at all the pros and cons of this strategic approach, both from patient's perspective and a program perspective. How long do they need to be on treatment on average? What's the acceptability, adherence, safety, obviously important, a strategy where you might contemplate more relapses, respiratory disability, and then a program perspective, are we breeding drug resistance? What's adherence like, and so on. So the problem with designing this trial, and this was 6 to 8 years ago, was actually even at that time there were quite a number of potential 8-week regimens that might do quite well in this. So difficulty was choosing between them, and actually as a sort of precursor of the modern trial designs, we went for an approach of testing a standard treatment versus 4 strategy arms, each of which had an initial 8-week regimen with a different combination. And those different combinations, we changed the rifampicin, so in 2 cases we pushed the dose up to 35 milligrams per kilogram. In 1 case we used rifapentin, in 1 regimen we used bedaquiline in place of rifampicin. And then we added on a 5th drug, linezolid at low dose in 3 cases, and clofazimine in 1 case. So those were the regimens based around standard treatment. And the idea was we'd do an adaptive design, so we'd start with those 4 strategy arms and have a data monitoring committee review the data and then stop any arms that were underperforming. In the end of the day, they actually didn't stop any arms that were underperforming or didn't recommend. And for practical reasons, the trial steering committee just made a decision to stop two of the treatment arms. So we ended up with 2 regimens that went through to final strategy analysis with the stop and retreat with standard treatment. And that's these 2. One was high-dose rifampicin with linezolid, isoniazid pyrazimide ethametol, and one was bedaquiline with linezolid and the other drugs. The trial recruited people with drug-susceptible disease. Initially, we screened out people with very heavy smear, big cavities on the chest x-rays, single cavity more than 4 centimeters, or HIV positive, but we removed those criteria towards the end because things were going well. The data monitoring committee was happy to increase the generalizability. It was predominantly an Asian trial, so 6 sites in Indonesia, 5 in Philippines, some sites in Thailand, in India, and then at the end we added Uganda for generalizability. Most of the recruitment from Indonesia, Philippines, Thailand here, Uganda came on at the end, did quite well, and then India about 2 weeks before COVID finally joined the trial. And then we had to shut it down. But we reached our recruitment targets to be able to get 2 of these strategy arms through to final analysis, compared with the standard of care. Again, a reminder, the primary outcome was week 96, unsatisfactory outcome. Then we look at all of the secondary outcomes. Now, this is published, so I've got a whole stack of slides dissecting these endpoints, but here's just a single summary slide in the interest of time. If you like this, the sound of this, please just go and look at the paper. We've explained it all, a whole bunch of outcomes. First thing was, we demonstrated this was feasible. One of the concerns was that with people so used to 6 months of treatment, they would hesitate to stop at 8 weeks, 2 months. Either the clinicians wouldn't, or the patients say, oh, just give me a bit more, I'm doing, But actually, people were very happy to stop at 56 days, exactly 8 weeks of treatment. Only a small proportion of people extended to 10 weeks or to 12 weeks. The main finding on the unsatisfactory outcome, the strategy was non-inferior to the standard treatment approach with a bedaquiline linezolid 5-drug regimen, but not with the rifampicin linezolid 5-drug regimen. That was outside of the pre-specified confidence interval for unsatisfactory outcome. And then in terms of the pros and cons, the big pro was that treatment time was reduced by half. So 80 days on average treatment as opposed to 180. Adherence, motivation was higher, participant acceptability was high. They would recommend it to friends or relatives with TB. It was safe. There was no excess of serious or severe adverse events. A low risk of drug resistance, just a couple of cases, one with clear risk factors in the bedaquiline regimen. The take-home message really is that there are alternatives to this over-treating the majority of people with TB. And these alternatives, or at least the one we tried here, can be successful. And really the idea is to open up the way of thinking, okay? So this was a first stab at, can we do things differently? And now what we're trying to do is explore this and take this forward because, there's a lot, I think there's a lot further we can go with this. This is just to acknowledge the huge amount of people who put time into this. Almost center in the slide, not quite, is Anjali, who led the effort in Thailand, Alina in Indonesia, Vincent, Philippines, Christine in Uganda, and Rohit in India, and the team in Singapore who ran this. So how could we improve this strategy? This was a first step. I think the key thing is to look at the decision around who stops and who extends, because if we can pick people who've got a high probability of relapse with 8 weeks of treatment and extend them a bit longer, that might improve the performance characteristics of the strategy. So that's what we're looking at now. What we did in the trial, as I mentioned, was symptom checklist and a smear. Symptom checklist, essentially, 40% of people are still symptomatic after 8 weeks of treatment, and that's largely driven by cough. So symptoms themselves are probably not very discriminatory. Smear's a bit better. The combination may be a bit better than the two. But what we've done is now do a multivariable analysis of all baseline demographic factors, other predictors, routine clinical biomarkers, including chest X-ray, gene expert smear, symptom score, and so on, to see what's the best predictor. Just at baseline, so when you start somebody on treatment, can you predict who's going to do well or badly with 8 weeks and say, actually, well, this person going to need longer? The answer is yes, you can. In the multivariable analysis, these are probably expected factors. So diabetes, double the risk of relapse with an 8-week treatment. Isoniazid resistance, again, double the risk. But look at this. This is gene expert disease burden converted from the cycle threshold. So people with high disease burden, low cycle threshold on gene expert at the start of treatment, if you give them 8 weeks, 7 times the risk of relapse. So we can at the beginning, we can already pick people who are going to need longer treatment. And this is just showing the same thing graphically, the clear separation that you can achieve in terms of prediction with gene experts. So certainly we can tweak the strategy there. What about biomarkers on treatment? Again, this is adjusted for gene expert at baseline and the other predictors. You can get predictive function also from a gene expert done at the end of treatment and say, this person needs to carry on, test again in 2 weeks or 4 weeks and so on. So biomarkers is really the second part of the trial, and that's what we're working on now. Can we just tweak this strategic approach to use biomarkers to get better performance from what's already working quite well as a treatment strategy. And now we're looking at all sorts of transcriptomics, proteomics, metabolomics. So far it's just been the routinely collected biomarker data. Now we can start to look at more sophisticated things that could be converted into a specific test. Also health economics, program implementation issues, et cetera, a lot we can go with this. So here's a summary. We've had, for drug-susceptible TB treatment shortening, we've had one success, which is the new 4-month regimen, rifampicin, moxifloxacin, but there are implementation challenges which are impeding take-up of that. High-dose rifampicin is potentially as good as rifampicin, but you might want to add a fluoroquinolone to that, just as they did with the rifampicin, moxifloxacin Study 31 trial. That's work that needs to be done and in progress, but there may be hope with high-dose rifampicin. There's a very healthy, by TB standards, new drug pipeline, very healthy funding for taking new drugs into phase 2, and innovative trial designs that may enable faster testing. So watch this space, because there's lots of new stuff going to come out over the next 2 or 3 years. Many more studies on host-directed therapy, although we're starting from a very low base, and then innovative treatment strategy, which may lead to more personalized treatment or programmatic, sensible things to do. Thanks very much again for your attention.